Hey folks, Scott Weingart here, and this is an EMCrit We. Today, following up on the drop I did on pulmonary embolism in 2026 that came out over the weekend. That was a members-only episode, so if you're like, I didn't hear that, then it's because you didn't join. Just go to emcrit.org and join, and then you won't have to ever miss anything, and you get CME and all sorts of good stuff. But I promised I'd have Josh on to talk about a whole bunch of the issues raised by the current state of pulmonary embolism in 2026. So that's what we have today. Now, in anticipation of that, number of listeners wrote in. Most of the stuff they asked for us to cover, I actually had time to bring up with Josh. One thing that came up was a couple of people, one of them Justin Morgenstern and one of them a EMCrit listener. They did not like my coverage of high petho. They wanted me to specify that the actual outcome was a composite endpoint within a composite endpoint. And is it really a positive trial? And yeah, it's a positive trial. I agree with them. The actual outcomes were not what I would have liked to see in a trial like that. And it's a very weak outcome. What both of them missed in their initial communication, Justin said he had understood this issue and just hadn't put it in his initial communications, is a bunch of those patients who had an elevated news score as their only piece of deterioration that made for a positive difference between the control group and the thrombolytic group was that a bunch of them got rescue therapy. I mean, almost all of them got rescue therapy. And I was going to discuss that here and what I think that does to your interpretation of the study results. But then I actually wound up having a phone call with Justin about this. So I'm going to talk to Josh. It's going to be about 25 minutes of jam-packed clinical stuff. And then at the end of it, and I'll warn you when it's about to start, I'm going to have about 45 minutes of a discussion with Justin. That is solely for EBM nerds. Nerds. You don't want to listen to that unless that's your gig. Or, I mean, maybe listen, but then I think you're not going to stick around for very long. We just go into the weeds of evidence-based medicine type stuff. So if that sounds like something you're going to salivate over, by all means, listen after the Josh Farkas piece. But if not, then don't feel any shame for abandoning ship at that point. All right, let's get into it. Farkas of EMCrit and the Internet Book of Critical Care and I discussing pulmonary embolism 2026. So if people don't know who you are, then they're not EMCrit listeners, so I'm not going to belabor any introductions. But we have Josh Farkas of EMCrit here, and we have some interesting PE developments, so I figured I'd get him on the line, and we do a joint EMCrit summit. How are you, Josh?
I'm good. How are you?
I'm excellent. All right, so we had the AHA guidelines drop. We have a few major studies come out. The PERT teams are going crazy. Let's talk about where we stand. I guess we should start with the AHA guidelines. Overall, good, bad, ugly, indifferent? What do you think?
There's one good thing about these guidelines, which is that they cite your paper with Aiken. Everything else in these guidelines is bad.
I don't disagree with you, but the feeling in my mind is it could have been so much worse. And so maybe I'm more indifferent than your utter disdain. But yes, they're not great. But I wish AHA would just stick with cardiology guidelines and let other organizations handle the other stuff. But seemingly that's not how it is to be.
So here's my question to you. So the ESC has this guideline that I think we've all been using about like intermediate, high risk, low risk PE. It's been utilized in various trials and road tested, and everyone knows what it means. And then the AHA-ACC comes along with this guideline, which is different. And I read the whole thing, and I cannot find any evidence to suggest that it's superior to the ESC guide stratification.
Oh, how could it? They have no support, except it makes coding for the PERT teams very easy.
I don't know. It just bugs me when guidelines do this. Like, we have a system of care that works, some sort of definition of sepsis that works, and then they come along. And in my mind, I feel like if you are going to replace something, you need some sort of evidentiary basis that this is better. And I don't think that necessarily needs to be amazing, but like at least like do a retrospective chart study of like 5,000 PE patients and apply this proposed system of stratification, apply the ESC stratification and show that it's better. Like, I don't see how you can recommend changing an entire risk stratification system just because you like it more.
Yeah, no, that makes complete sense. Do you think it'll take off? Do you think the fact that I think many of the people on the writing committee for these guidelines are PERT, and if PERTs push this, then it's going to be the way things are. What do you think of the uptake of this?
I'm hopeful that we can kill it.
Oh, we've said this so many times in the past.
We'll probably fail, but we have the ESC and the European guidelines support us in doing that. And this whole like A through E2 with R, it's so confusing and counterintuitive. I'm hoping that this will kind of just go away.
All right. It is May the 4th, so this tiny group of rebellion might persevere. We'll see. All right. So let's talk about some of the things in these guidelines. What do you think about the anticoagulation recommendations in the sicker patients? Low molecular weight heparin, even for those patients.
I still prefer a heparin infusion for sicker patients. I think it gives you more flexibility in terms of if there's bleeding, you can stop it. If you decide to do some sort of alteplase, you can stop it, you can down titrate it. So for the truly sick patients who are going to the ICU, I would still tend to prefer heparin infusion. Now, I do want to acknowledge that there has been some bleeding of that recommendation into like the lower risk, low submassive patients who are going to the floor, who are getting heparin drips, who should probably be getting low molecular weight heparin.
Now, these studies that have come out recently using low-dose systemic thrombolysis or its equivalent in the form of catheter-directed thrombolysis, they were using concurrent anticoagulation. In the Aiken study, they did not use concurrent heparin. They waited till afterwards, which has always been your stance. Do you think these bleeding risks are the concurrent use of heparin and the thrombolytics at the same time?
It's hard to know. Honestly, the bleeding rates in these trials are so low. We're talking like 0.5%. And the problem is, in order to power a study large enough to see a difference in those bleeding rates, you'd need like thousands of patients. So I think it's difficult from an evidentiary basis to compare the super low bleeding risk in any of these trials, with the exception of PETA-1, where they combined like full dose tenecteplase and full dose heparin, which is just like a bloodbath. That is an absolute disaster. Nobody should ever do that.
Are you right now, if you use a low-dose thrombolytic infusion, whether through catheters or through systemic thrombolysis, are you waiting on your heparin in your own practice?
I think it depends a little bit on the situation and the patient. For example, like if the patient is already on a heparin infusion and they've been on a heparin infusion for several hours and their 10A level is perfect, and depending on how sick they are, I think it could be reasonable to add a low-dose TPA infusion on top without stopping it. So I think you need to just consider like where you are in the heparin infusion picture and how sick the patient is. And yeah.
Let's talk about some of this risk stratification. So one interesting group for the AHA's classification is the C3 group. And these are patients that they talk about as abnormal right ventricle and elevated biomarkers. Their biomarkers include BNP, which we both think was not supposed to be there. I think lactate would have a smarter role there. So what would you do with a patient with abnormal RV, elevated troponin, and a lactate of like 2.1? Is that a patient you watch like a hawk, or do you think that patient, if they're low bleeding risk, deserves some type of intervention?
So I think one thing that has been done wrong for a long time, and I think we've all maybe been guilty of this, is I think that we may have drawn the line for the RV to LV ratio in the wrong place. So when I think you look at like the stratified trial, for example, like a patient, and obviously like it's not a binary division. So there's a huge difference between like an RV to LV ratio of about unity in roughly 1, maybe like 1.1 or like 1.7, or like a huge RV with just like a tiny little LV. So I think that is one potential weakness of these stratification systems. And honestly, like I was disappointed by the magnitude of benefit in the stratified trial and the high PETO trial. And I do think moving forward, I am thinking a little bit differently about patients with like an RV-LV of like 1.1. So I think that's worth considering. I sent you this whole sheet thing of like all the different risk factors. And I think like it's difficult to group these patients into perfect boxes. We try to do this. Every individual and risk stratification system tries to kind of like create these discrete boxes. But obviously patients are continuous and they don't always fit into the boxes. So I feel like at the end of the day, we need to like look at all of these factors and try to find some sort of unity or kind of direction that most of them are pointing us into.
Yeah, that's fair. The thing I was trying to act as a stimulus for is on your sheet, which is super cool. And could we put that in the show notes, Josh?
Absolutely.
All right, great. You have there that a lactate greater than 2 has a odds ratio of 12 for was it bad? I forgot the exact outcome but it was something bad.
Yeah, it's usually like hemodynamic deterioration and stuff like that.
Okay, so that's why I said, what do you do with these patients who have no real hemodynamic perturbations yet, but a lactate of 2.1? Is that a patient you would consider earlier intervention or just watch?
I think that would start moving me into what I loosely call an intermediate actionable PE classification. So I kind of came up with this list of criteria that kind of pushes me to act on these patients. So that's like lactate over 2, patients who clinically look shocked, shock index over 1, borderline blood pressure, transient hypotension, syncope, pre-syncope, contrast reflux in the IVC. There's actually been some new literature over the last couple of years that seems to be a robust predictor of poor outcome. And that's something that I'm paying a lot more attention to, by the way.
Okay.
If you see a lot of contrast below the diaphragm into the liver, into the IVC, that's really bad, especially if it's layering in the IVC. I saw one of those patients recently in clot transit. So I think like if they have a lactate of like 2.1 or 2.2, but none of those other indicators, I'm not entirely sure if I would give them systemic TPA, but usually these things tend to move together. So usually if the lactate's over 2, then they're also going to have like a borderline blood pressure and like maybe an increased cap refill. And once you see a conglomeration of those, what I'm calling intermediate actionable features, that would push me to do something more than heparin.
All right, that sounds fair. And that's kind of, I sent you the EMCrit risk stratification. And I think that it's in keeping with where I currently have it. The borderline submassives are watch and consider, but not go for. All right, so then for me, I have this middle group of 6 submassive and even the mild massive, the Aiken group of low dose vasopressor, but not escalating care. And I treat all of those in my mind the same way, which at 2026 would be low dose systemic thrombolysis or mechanical thrombectomy. Where do you stand on that group of patients, the sick submassive or even the very lowest category of massive P?
I think it's challenging to kind of like make a recommendation about all these patients because sometimes the patients don't fit into the boxes exactly. One issue that I do struggle with a little bit is for patients with respiratory distress who require a lot of oxygen. I feel like most of the patients with PE die from cardiovascular collapse rather than respiratory failure. And I do feel like another challenge that we're facing is a lot of our patients are super complicated and have like a lot of respiratory comorbidities. So this can get challenging. For example, like you have a patient who's on like chronic obesity hypoventilation syndrome or chronic COPD, and then they start hitting one of these like respiratory metrics and their likelihood of dying from the PE may be low. So I feel like there's a lot of nuance to just like looking at the bigger picture here. It's really hard to come up with guidelines, which I think is honestly like why the clinician needs to be at the bedside, just like looking at all these different factors.
Oh, I think that's very fair. And maybe that one should be modified. But forget about the stratification that gets you there. You have a patient who you have now deemed to be either sick submassive or what the ESC would call the high risk intermediate or the very lowest of massive. Forget how they got there. You're convinced I want to intervene. The question to you is, what are your intervention options in a patient who is low, maybe even moderate? Let's just stick with low. We'll really see that first. What do you consider even on the menu? Because my menu options have markedly decreased now in 2026. What are yours?
Yeah. So I think this certainly depends on where you work and what options are available at your center and kind of the typical practice patterns. Until Peerless 2 comes out, I think it's going to be difficult to provide evidence-based guidelines on like catheter-directed thrombectomy versus TPA. So I agree with you. There's this group of patients where we want to do something. At my shop, that's often going to be catheter-directed thrombectomy. Our radiologists are really good at this. They can basically like suck out a ton of clot. They get that like great picture of all the clot. The patient comes back. They feel great. They can go home quickly. It kind of like allows them to do physical therapy, get back on their feet. So that's often what we're moving to. If the patient, that option may not be available like 24/7. If the patient's coming in at like 3 a.m, or sometimes there are potential contraindications to thrombectomy. For example, there's a weight maximum on our table. So I think another possibility for that group would be some sort of like low dose TPA, like 18 milligrams over 6 hours based on like the PETO2 trial.
Yeah, that's exactly what I have on the list. So either systemic thrombolysis or mechanical thrombectomy. So I think we're very much on the same place on these patients. Now, what would you say to places that still want to do catheter-directed thrombolysis?
Like the vibrating catheter, the catheter.
Forget it, whether it be just standard PA or ultrasound assisted. I think they fit in the same category of, in my mind, obsolete.
I think, yeah, I agree. I think this is obsolete. I think it's a waste of time. I'm unaware of any evidence that giving TPA into the pulmonary artery is superior to giving it into a peripheral vein. We've all done bubble studies. If you infuse alteplase into the peripheral vein, it's going to be in the PA within like 1 second. So I think these patients need therapy. And if that's what it takes to like check the boxes at your institution to give this, I think one really fascinating aspect of this is the medical legal ramifications. Okay. So if I give someone like 18 milligrams of peripheral TPA on my own, I'm taking medical legal responsibility for that. And if anything goes wrong, they're going to say it's my fault. Whereas if I consult an interventional radiologist and they do this procedure, there's like this diffusion of responsibility where both of us agree that this intervention is beneficial. And I feel like, honestly, some of the push to send patients to IR, sometimes like we're reticent to give patients a TPA and take that responsibility on our own. So like if you have to put in this catheter to like make everyone happy and give the patient low dose TPA, like that's fine. It's probably going to be effective, but I think it would be safer and easier to do peripheral TPA. When you're subjecting these patients to a risk of a procedure that can cause bleeding, and if there is clot in the pulmonary artery, like you might not want to be like sticking a catheter in there that could potentially like shift things around or make things worse.
Let's talk about this sick massive group. Now, for me, I think the low dose systemic thrombolysis is kind of off the table. And I think if you have them available, mechanical thrombectomy or ECMO are the way to go. And then you have in your back pocket, I think, half dose systemic thrombolysis, only to temporize or if you're at a place where you can't get either of the other two therapies. Are you on the same page?
I think we're basically on the same page here. So there was that randomized controlled trial in chest several years ago comparing half dose and full dose TPA, and there was no difference. So I think for the vast majority of patients, half dose TPA is perfectly fine. If I'm faced with like a really young patient, like an 18-year-old who's like actively dying of PE, and I feel like it's super high risk of dying and the risk of an intracranial hemorrhage is very low, I might give 100 milligrams of TPA. But I think we're in alignment that for most patients, half dose TPA probably gets you the same benefit with less bleeding.
That brings up another question on my list. For me, my tendency has been, simply because of the reason you mentioned of I'm taking all of the risk on myself when I do this low dose TPA infusion. I have been taking when the patient is not crashing, which is pretty much all of the low dose patients, getting a head CT. Now, if I'm smart enough and I really suspect PE, I get it during the initial CT angio. But I've actually taken to sending patients back as we're getting ready to start that low dose infusion. Do you think there's any benefit to that? Do you think that's just me like trying to put on belt and suspenders? Like, have you ever done this? What's your stance on this?
That comes up every once in a while. And usually the situation is like a patient with PE syncopized and they hit their head and folks want to get a CT scan before giving TPA. In all those situations, it's been negative. So I think it's probably low yield, but at the same time, if the patient's stable, I love CT scans. I think everyone should just get a CT scan all the time.
Yeah, I'm worried more about the big intracranial mass that's sitting there. But yeah, I certainly, if they hit their head, I think it would be a no-brainer, no pun intended. All right, what are you doing on the pericode patient? You don't have ECMO in this example.
So for pericode patient, typically we'll give like an alteplase bolus, probably 50 milligrams. We'll do inhaled epoprostenol. You can combine inhaled epoprostenol and inhaled nitric simultaneously. So sometimes that can get you out of trouble. I love epinephrine. Folks get into this like norepi versus epi. I'm a big epinephrine fan for these folks. Those would be my usual moves.
Yeah. All right. That all sounds good. What about clot in transit?
Yeah. So this is interesting. And I think this needs to be like broken down into a couple different pieces. And honestly, I feel like the literature does a pretty bad job of like discussing this because there are different types of clots in transit. In my brain, I break this into three different groups. So one group is like patients where there's just like this little tiny, unimpressive little bit of clot on the tricuspid valve. And honestly, I don't think you need to do a whole lot about that. So like in the life cycle of every pulmonary embolism, at some point, the pulmonary embolism went through the tricuspid valve. Maybe like that's like its college phase or its high school phase. So I'm a believer that if there's just like a little bit of thrombus stuck to the tricuspid valve and it's not that exciting, like that doesn't really change things for me. So that's one group. The second group is like a huge clot that's like whipping around in the RV that looks terrifying. And I think that would probably bump things up for me to take that patient more seriously, maybe intervene more aggressively, maybe consider some TPA more carefully. Maybe if you have angiovac, you could try to suck it out. Although in practice, I've never actually seen that scenario. The third is the clot that's going across a patent foraminal valley. So that is basically extending into the left atrium and threatening to cause a stroke. So if you give those patients TPA, you break that thing in half, it could cause a stroke. So that last group is the scariest group for me. And those are patients where I'm talking to a cardiac surgeon about potentially cracking open the chest and just ripping it out because I'm worried it's going to cause a massive stroke.
That's a great breakdown. That's fantastic. All right. And would you be using the low-dose systemic thrombolysis in your category 2, group 2 patients you just mentioned?
Yeah, I might. I'd probably, depending on all of the other indicators of illness, I'd consider either like a low dose or maybe like a half dose TPA if they're sicker.
Yep. All right. That's great. Aside from the case you just mentioned of the patent foraminal valley patient, I don't really know where cardiac surgery fits in anymore with really good catheter-directed thrombectomy on the table, even through transfer if necessary. Like surgical embolectomy just seems like a grievous operation. Is that dead in 2026? Who would you refer for surgical embo at this point?
Not very many patients. So the first thing is, it's really interesting when we think about risk stratification and the actual quantification of risk. So there's this whole like list of contraindications to lytics. It's not really well evidence-based. It's like things that make us scared. Most of the time, if you give lytics to patients who have like one of those contraindications, they'll be totally fine. The evidence on CT surgery for PE is like, it's CT surgery. It's a big deal. And it comes with all of the risks of CT surgery, which are very substantial. And somewhere in my chapter, I have like all the risks of like death and complications, and they're quite substantial. So I think overall, we tend to overestimate the risk of TPA and we tend to underestimate the risk of CT surgery. And once again, I think that comes back to like taking on risk for ourselves versus like blaming everything on a surgeon. So if we send a patient for surgery, we're like, oh, we're done. The patient goes for surgery. Anything bad happens, that's on the surgeon. So kind of taking this back, I think there's very minimal role for surgery. With the clot extending across the patent foraminal valley, that would be an indication for me to talk to a surgeon. I think the other issue that I have run across is sometimes we do see these clots that are basically just rubber, like they've been there forever. You give TPA and like nothing happens. Like this is just like a hunk of like completely rubberized fibrin. So those patients, hopefully they can get thrombectomy, but if they can't get thrombectomy and TPA can't work, then you might be in a situation where surgery would be on the table. But honestly, it's like incredibly rare.
Yeah, that seems fair. All right, let's do. Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Some rapid fires. You diagnose a fairly significant pulmonary embolism. Do you get a DVT study at that point, or do you wait?
Honestly, I don't. There are so many factors, and part of this is just logistics. In my perfect universe, I would, and this isn't evidence-based, but I'm just going to say this. In my imaginary perfect universe, it would be cool to run these folks through a CT scanner and just look at the clot burden in their groin is when we get the CT angio. That's not been evidence-based, so I'm not recommending it. So just to be clear about that. just from like a throughput standpoint, like these decisions need to be made pretty quickly. And I like to try to approach these patients in a standardized fashion. So I don't want to delay making decisions based on, for example, like getting a DVT scan. And then the other thing with pulmonary embolism is like there are about like probably 30 different risk factors that affect risk stratification. And I think at a certain point, like it's just like too much data where like if like 15 risk factors are suggesting a poor outcome and like 5 are suggesting a good outcome and you add another risk factor, like I'm not sure that that actually like affects things a whole lot. So my general practice is basically not to look for DVTs. That was a long walk to get there. But
are you doing a POCUS on even inconsequential CT?
I never, maybe this is going to get me some hatred, but I never POCUS these patients ever.
So you're just using CT to look at the
I'm just
RV to
straight up
elevation.
CT guy. The reason for that is I like the CT. It's objective. I can see it from a distance. So a lot of these PERT activations for me, they're coming from other hospitals. I feel like the echo, like a lot of times the windows aren't great. I feel like the interpretation can be subjective. The data is not stored anywhere. I just feel like it doesn't add a lot of data to me. And I do think that, especially with this evidence coming out about CT scans, looking at contrast reflux into the IVC, I can like measure the RV to LV ratio. I can look at the clot burden. Like that to me is the truth. You can put it in the bank. And I feel like, once again, getting back to this theme of like more data is not necessarily better data. I don't think that like the adrenalized patient, like clinician, like rushing around and doing like a bedside echo and like looking at the RV, I don't think that adds anything.
Love it. All right. And why wouldn't they just give us all this on the report automatically if you order a CT-PA of the chest? That's like...
Oh, I hope they don't.
Oh, really? Oh, tell me why.
Well, I think the problem that I'm joking, but so I remember back, like I'm sure you do too, like about 12 years ago, like when we ordered a CT angio, like no one commented on the RV.
Yes,
like the RV was
absolutely.
like a black box.
100%.
And the scan would come back and it would just be like large PE. And people would be like, okay, we're going to treat with heparin. And I think over the last dozen years, there's been increasing awareness of like big PEs and RV strain. And it's caused like a huge headache for us because we get all these patients who have like COPD or obesity hypoventilation syndrome, and their RV is huge all the time. And then they'll get like a little PE, and then the radiologist will comment on the fact that the RV is dilated and it like hits off this huge PERT, which I think is fine, and that's what should happen. But I think it's generated like a huge source of noise. So I think it would be useful for radiologists to put that in, but at the same time, I think you have to be mindful of the fact that like clinicians see these things and oftentimes they're not fully adept at really interpreting them.
Yeah, no, that's fair. Though I got to argue the qualitative stuff they're already putting in is going to be far more damning for you getting extra PERT calls than them putting in ratios and stuff like that. That probably is not going to be read by people who aren't actually looking for it. Okay, what is AI going to do in the treatment of sick PE patients?
You know, I think it'll probably read these CT scans super quickly and it could accelerate things a little bit. I'd be interested to see, I think honestly, one huge challenge that I've talked about a couple times already is how to integrate all these different pieces of information. So there's like a million studies on risk prediction, pulmonary embolism, and they all look at like one thing. So they'll be like big RV is bad. And then there'll be a different study that says like low TAPSE is bad. And then our challenge as a clinician is to like integrate these 20 pieces of information. And to my knowledge, there's not been any study that actually like looked at how to put all of these pieces of information together, like which of them provide independent prognostic information and which of them are like redundant. For example, like if the RV is big on CT and the RV is big on echo, like that's like redundant information. So it would be amazing if someone could take some sort of like huge hospital database of like 1,000 patients with PE and like scan all of the CT angios in and then like run it through some sort of AI algorithm and see if the AI could like extract information. And I bet you if you could feed AI like the full CT scan, like every single cut, all of the information from the CT scan and the ECG, which has a ton of information, and I think that's often overlooked, by the way, and like a couple labs and vital signs, I bet it could probably outperform us as far as prognostication.
Yeah, no, I think that's inevitable for sure. All right, let's see. What did I miss? What should we talk about, Josh, that I have not hit?
I want to give a shout out to this little like PE worksheet thing that I made.
Yeah.
We'll be putting it up in the show notes. I made it a little while ago and I've used it a couple times and I think it's fun just to, it's like a worksheet you go through and you fill out all the data. I found it to be helpful just to force you to be a little bit more systematic about things. I think one pitfall that we fall into with lots of times with PE is like, we'll be hung up on like the clot burden, or there'll be like a troponin or like one aspect of the case that kind of like gets our attention, and filling out the worksheet forces you to be like, wait a second, like there's no ECG abnormality. Like the ECG is stone cold normal. Like the vital signs are okay. So like maybe that like troponin of 3 was due to like atrial fibrillation, or like, so it just slows you down. And I have actually found that it affected my management a little bit, which is interesting.
Yeah, it's a good work. It's lacking one major thing, which is those AHA classifications in bold letters. So I don't think I could use it because it doesn't have that A through E on there, Josh. I think version 2 maybe is ready.
Never. I'm going to move to Europe.
All right. Is there anything else we should hit before bidding folks goodbye?
No, I think this was great. Yeah, and I think that the Stratify trial and the HiPetho have moved us forward, and it's pretty exciting.
Yep, I agree with you. Though people kind of hate on both of the trials with good reason. HiPetho being like a subjective assessment of the hemodynamic collapse, and inexplicably, like, why do you think Stratify didn't include sick patients? That would have been much more game changing than the patients they actually included.
I think this is like the chronic struggle in critical care, which is that if we include the sickest patients that we're most interested in, it's just like those patients are very rare and it's hard to capture them. So we're forced to either have like a super tiny trial with the sickest patients or a larger trial with less sick patients. So I think this is just like the reality of these trials. And one other thing that I do think about a little bit is just like experientially, it seems like patients these days are doing a bit better than they used to. And I do wonder if we're doing better at finding all of these patients systematically and including more of them. So like in your brain, if you like think back to like a dozen years ago, when you think of like an intermediate high risk PE patient or an intermediate risk, those are probably sicker, and there were probably some like less sick patients who were just flying under the radar. Whereas now we're like more systematic about identifying every single one of these patients.
That makes sense. All right, Josh. Well, I can't thank you enough, and people love it when we have you on. So there you go, a little treat for the listeners.
Yeah, thank you.
Okay, so as mentioned at the top of the script, now we're going to go into the conversation I have with Justin Morgenstern, who is an EM physician in Canada, also the author of the First 10 EM blog, and just a brilliant maven of all things clinical evidence-based medicine in emergency medicine. So let's get into that. And if you're not an EBM wonk, then maybe this is where you sign off. All right. Well, let me walk you down this primrose path and we'll see where we get.
Yeah.
I think from your post, you agree there is probably a subset of patients who aren't hypotensive who could decompensate in hospital. Is that right?
Yeah, I think I have to preface it with I think that could be biased. Like I'm willing to say that I could be proven wrong, but I'm at like 90, 95%. It's not like nothing's 100. But yes,
sure.
I think we both agree that lytics are going to work in some sick patients. 100%. Yeah,
absolutely. All right. And then do you agree that we shouldn't be trying to find a group of those patients in which without intervention, there's a incredibly high number for mortality?
Sorry, say again.
Okay, well, let me put it into numbers here.
Yeah.
Like you could say, oh, well, we should only intervene when these patients have like a 50% risk of mortality. That would be very supported in terms of like, yeah, we definitely should intervene on those patients, but that's probably not an adequate sensitivity to really catch what we're looking for, which is preventing them from even getting to the point where they're crashing out. Someone has to rush to their bedside, either take them to IR or administer therapies. So we generally pull back from a number like 50% to some other lower number.
100%. We both agree there's definitely a huge population of PE that doesn't need this, a population that we're never going to test it in, even if we can't prove it 100%. And what we're really focusing on, what we're trying to find is the right group of patients to intervene on. And actually, the right across the board, because I still am not 100% sure that when they rescued that they had selected the right patients. We don't know that. And so, yeah, sure, it's all about finding those patients.
I'm going to walk you there. I think we'll see at which point you diverge, because we're still in the same place here. Yeah. Would you agree that systemic thrombolysis in this group of non-hypotensive sick patients actually changes their hemodynamic outcomes?
Yeah, based on this, I
wish they gave us more details. Let's exempt this trial from the discussion at this point, and then, because what I'm trying to set the stage for is that my assertion is we have a foundational set of beliefs we believe to be true. Again, not 100%, but we really believe them to be true, and we base our care on it before we even analyze a trial like high-PITHO.
Yeah, I think that is true. I think, and then maybe you're already right at the point where we're going to diverge. I am not sure that the stuff that they're measuring in the news score or the
we're not there yet, brother.
Any of it, I'm not sure that any of that is capturing.
We'll get there, but we're not there yet. We're not even looking at high-PITHO yet.
Yeah, looking at all the trials, I do think that lytics changes something physiologically, without a doubt. Yeah.
And just to bolster that, here's Chatterjee's meta-analysis, which took, I think, all of the extent trials of systemic thrombolysis. This one is specifically in the exact patients we're talking about. Intermediate classification, pulmonary embolism, submassive by AHA, intermediate high risk by the ERC. And when they look at the trials, they even went a step further, and there's some like additional test of like how firm we are, some test of assurance, and they feel fairly strongly that thrombolytics will decrease mortality in this group of patients who are on the high end of that intermediate group. Are you, again, not with 100% assurance, but do you buy that?
Yeah, I think with less, I've gone through these studies. It's funny because there's been like 4 or 5 meta-analyses that say decreased mortality, and yet nobody's doing it, which is really interesting. Nobody got on board. And so there's clearly out there a consensus that there's more uncertainty than is put across than the meta-analysis numbers. Nobody's doing it in terms of nobody's doing it in terms of so. That meta-analysis is systemic thrombolysis, right? That is where it was. Things have changed.
Header-directed, half dose. It's a mixed bag of a variety of means of getting thrombolysis into the patient's bloodstream. Maybe that's the updated one, because there are a bunch of meta-analyses like this. The data has changed in 10, 15 years. The meta-analyses have consistently said all-cause mortality goes down in intermediate PE using systemic thrombolysis. Correct.
Now, reading those individual studies, they're unblinded, they're not perfect. So there's a reason that lots of people haven't jumped immediately on board, and it's not just fear of thrombolysis. So I have a lot more uncertainty in there, but I 100% agree. There's a very good signal that there is a group of patients that is going to benefit dramatically. But the problem is the same with the other two, Stratify and whatever, Storm PE. When you're starting with a group of patients that has a risk of mortality of 1% or less, how is the meta-analysis showing mortality benefit going to apply? Because there is no mortality, right? So you need, I don't know, it's not 50%, but it can't be 1% or like zero. I think Storm PE was 0%. Like it's got to be 4 or 5%. It's got to be somewhere higher than nothing to get a benefit, right?
Hey, it's Future Weingart popping in here. This is a point I'm going to make later on, but I want to foreshadow it here because I think it's really a key point. And Justin does address it, but I think it kind of gets lost in the back and forth, which is these most recent trials of the group we're talking about, the high-risk intermediate. Yes, they have a very low mortality in both groups, but that's because, at least in the trials I've looked at, the patients who are not receiving the intervention therapy are put into a rescue therapy group in which they do get, in essence, the intervention therapy almost every time. And that just goes to the fact that people do believe the evidence that intervening on this group actually does save lives. And that's what that meta-analysis would see. And so I don't think you're going to see trials unless they ban rescue therapy, and no trial could do that I know of in the United States, at least. I don't think anywhere in the civilized world they're going to ban rescue therapy. You're not going to see the mortality numbers anymore because people have accepted that it's necessary to intervene. So when they hit some threshold of like, all right, I don't feel comfortable leaving these patients anymore, they do get the intervention. These interventions now are very safe, and then their mortality is not going to be there. So that, I think, is my answer to the point, and I will mention it later, but I just want to hit it now. It has to be higher than nothing, and we could argue what that should be. If you showed me 5%, I think that's actually a very reasonable group to intervene on if you have a low-risk intervention. When you have an ultra-low-risk intervention, and this was what I was going to respond to your email, like lipid therapy for prevention of acute coronary disease, it's vanishingly small, the absolute benefits from that therapy that now has you on a medication for life. And it's not without side effects, and yet it's like redounded throughout all of cardiovascular therapy that this is like a no-brainer. So
although it's funny because that was actually one of the examples I had, it came to my mind as well. And that has dramatically changed since I started practicing. We used to do primary prevention. Now we don't. We try to find the higher risk population. We only do secondary prevention now, which is what I'm arguing here. We need to find the higher risk. We don't do it for everyone.
It's funny, maybe it differs in Canada. The United States has become more aggressive. Like we are now doing primary prevention of patients at much lower levels of LDL lipids. So I don't know, maybe this is a divergence between our countries, but we are aggressive.
Yeah, no, I thought all the guidelines had gotten way less aggressive. Hypertension, they've gotten crazy because they keep lowering the number, but aspirin and like lipids in females, all the guidelines, I haven't been in family medicine.
I don't know, I'd have to look again, but from what I follow from like Peter Attia's stuff that I just see popping up in my feed, the current guidelines are insane. Like my doctors have been salivating to get me on these therapies with no other risk factors other than LDL. And so I guess it just depends on which recommendations your country is using for LDL therapy. But I could consider a host of other examples where very small absolute mortality differences still prompt therapies that are considered relatively low risk.
Yeah, I think that maybe this is the crux, and there's a grammatical but a real difference. Are we aiming for a preventative therapy or a therapeutic therapy? So I just did a big thing on strep throat, and you look at peritonsillar abscess, and people talk about that as a complication. And if it's a complication, then you need to do preventative therapy, and you need to give antibiotics to everybody. But when I read literature, it's only the select few that have, on presentation, unilateral severe pain. I think you're actually doing therapeutic effect, and what you should be doing is selecting the highest risk patients. So you give antibiotics to the 1% who are going to go on to have peritonsillar abscess, not to everybody hoping you can prevent peritonsillar abscess. And when I look at the population of this trial, I think we're closer to the preventative. Let's give it to everybody because the baseline risk just looks to be so low. To me, this is a wait and see. The rescue therapy is exactly where I would want to be in this trial. They waited, they saw, and nothing bad happened. This trial almost basically proves that waiting and see, because every clinical outcome was identical. So they waited appropriately. And instead of 100% of people having to have lytics and Ps, not that high risk thing, but it's still lytics. So instead of 100% of people having to have it, 7% of people had, or 9% of people had to have it or whatever, that seems like the right approach. They basically prove that wait and see is the better approach.
I don't know if I'd take that same conclusion. I don't know if I'd really make that choice if it was me, if the therapy we're talking about is low risk. Now, when they did the original PITHO, yeah, I don't want that unless I'm actually needing rescue, right? Like their bleed rates were bad. Full dose tenecteplase plus heparin. So that's I agree with you. But that's not what we're talking about here. We're talking about therapies that have an incredibly low risk and seemingly an insignificant risk above heparin alone. So if that's the case, wouldn't that markedly change? Let's say we had a magnetic therapy that just broke up the clot that has like no bleeding risk. You'd probably say, no, don't wait for rescue. Send every patient who has even a 2% mortality and a higher risk of decompensation. And there's always the chance that decompensation is going to lead to some degree of sequelae that's not being measured by the outcomes here. Kidneys don't generally like being at a MAP of 45 for a while. You'd probably say, yeah, run that patient through that magnetic non-bleeding risk inducing therapy. Yeah. Do you disagree?
Yeah, so I think one of the problems, it's almost maybe the exact same argument that I didn't email you directly about for the RSI trial and my disagreements with you there about trying to really get into the nitty gritty that comes around to all the secondary outcomes when you have what you really care about way up front as the thing that is probably most proven. And so it's true, but if the harms are so low, the trial is designed, or should have been. Unfortunately, they made their primary outcome crap. But table 4, they measured all of the real long-term clinical outcomes. And so if you had gotten to a point where the harms are so low that the benefits have to outweigh it, you would find benefits. We didn't find benefit. Like the only benefit of getting harms lower and lower is to get to a point where there's actually truly a benefit. And if there was, we would have seen a benefit. We see zero benefit here.
No,
right?
Your point is well taken, but it's not being made in a fair way.
At 7 days, at 14 days, at 90 days, there is no clinical difference between these two groups.
You're too clever to not know you're slightly alighting on the real issue, which is there's a difference between we see a signal and we know it's statistically insignificant because we don't have numbers to in any way support a signal versus what is capable of being a statistically relevant result.
But this and every other trial, the signal mortality is 50% higher.
Yeah, no,
in
I'm
the
not even
intervention
talking
group.
about high peak though. I'm talking about
But across all of these trials, so not going back to the meta-analysis, that's true. But across all the most recent ones, whatever the two, Stratify and something like all the most recent trials I've seen have zero mortality in the control group and mortality in the intervention group. Like that's going in the wrong direction. We're finding the wrong population if that's the case.
Yeah, Stratify is not even shouldn't even be put up in this
Yeah,
measure
sure,
because
yeah.
they chose patients that were so not sick. It was almost laughable why they did the study. And I'm going with the baseline data. Before these patients were all crossed over, there was hemodynamic decompensation, not like news score hemodynamic decompensation, like needed to be put on crash pressors, moved to the IC, potentially period of time on very low MAPS, patients requiring emergent rescue therapy. And mortality. Like that's the foundation going into these trials. Then you get to a situation where, at least in the United States, it's just not considered acceptable anymore based on that to not intervene once the patient has a hemodynamic decompensation. That's just considered
And that's sort of my problem.
Okay, tell me.
Is that, well, because we are assuming that the idea that you have to intervene, it has baked into it the assumption that your intervention actually has benefit. And
But you're ignoring what you just said about the meta-analyses. You agree that all of them show, before we crossed all these patients over, that there was
I can't remember when I said
benefit.
it. I did a very long post on it. I agree that the systematic review does it with a bunch of problems. I don't think anybody out there before people have gotten on board because they love the interventional stuff. That has changed the conversation. But from an evidence-based standpoint, when it was just, am I going to give systemic thrombolysis or not? Nobody was giving it. Or like there was a balance, but it was like 95% against to 5-4 in that realm. So people did not believe the results of that systematic review and meta-analysis. My result of that was very hard for the clinician. But that meta-analysis says we need one really good study, which is the kind of thing that high PETHO should be. Like we're at the stage where we need an RCT and I think it'll be positive if you identify the right population. But I do not think we're at the point where we know for sure that these lytics work and improve mortality in the groups of patients that we're looking at. And to say that you have to have rescue therapy, it has baked into it the assumption that you are reducing mortality.
If you have a scenario, and I'm not saying this is truth in the world, I'm simply positing as a hypothesis. If you have a scenario where you need large enough numbers and you're not going to get them from the individual trials, it's really where meta-analyses shine. And the meta-analyses, you've said there's 3 of them, all say the same thing. And you've said that earlier in this discussion, that in places at a time before people felt intervention was absolutely de rigueur, that there was a mortality difference, that it was not a borderline result, that all 3 meta-analyses, yes, they're looking at the same studies, but to see multiple authors come to the same conclusion that if you do nothing on a group of these patients. But
the same bias studies. So like this, like at the time they're like, I was a believer, but I still didn't know which patients to give it in.
Mortality is a tough one to be biased on.
Yes and no, and I have to go back. I remember having some major problems reading some of the individual studies, but it's been 2 years since I
that
did.
Could be happening, and yet if they take the mortality numbers, then there's still mortality numbers. It's like the few things where it's not really the bias of the observer really coming into morgue determinations.
But again, I think you're still flipping it on its head. So let's assume that in a patient that has a 5 to 10% mortality, which is what those previous studies
I'd even say
were
5,
finding.
like 10
there is a
over-exaggerated.
whatever. But so we say there is a mortality benefit in those patients. What that doesn't prove at all is in when these studies that we're looking at that anybody that got the therapy was actually at risk of mortality. Right. This, to me, you look at you can't tell. They don't give us enough data. But these patients who went for rescue therapy, I know doctors, they love to escalate for fucking anything. Like it could be financial reasons they want to. PERT teams want to intervene. So I don't know that there's anything here that says that these patients actually benefited from these rescues.
No, well, again, you're not accepting the foundations, but yet you say the words that should make you accept the foundations. If we accept the foundation of there is a mortality signal when these patients receive nothing, and we accept that in the United States, at least, it's considered good clinical care to take this high-risk intermediate group and do something on them, then the fact that the patients didn't automatically get rescue therapy would be the outlier. The fact that if you accept the foundation that there is a mortality in these patients, as long as you get the same subgroup, and these patients were in that subgroup, you could argue, I don't know how they got high PETHO through the IRB without all of these patients going to rescue therapy.
I don't think that's because I think you're very much overstating what, at least around the world, people actually think of these therapies. Aside from, again, these proteins have come on and really changed the game because they want to justify their existence. And so the PE world has changed, not because some big study came out, but because there's things that people can do like that practically. So the problem with the jump you made is we can say that there is a signal towards mortality benefit in these patients, and there is wide confidence intervals around that. I don't know. I would put it at 75% that we're going to find the right population. But most of the world, before PERT teams really started pushing this over the last 5 years, most of the world did not believe that signal was enough to give thrombolysis. So the jump was, I think, maybe recently, whether it's the perf teams or just where you're working, your jump was now it's accepted. You jump from there seems to be a signal in this meta-analysis to this is accepted standard. It's not been accepted standard anywhere.
It's the United States accepted standard.
Yeah,
maybe
so
you could argue
it's going to be hard to run
the teams, but
it's going to be hard
I think
to
you're being a little bit
cynical
cynical about their reason for existence. And I'm not a fan of PERT teams, but this is not the reason why. I think there is a group of high-risk intermediates that definitely deserve therapy. And I think I have the evidence to support that.
But I've spent 10 to 12 years talking to ICUs, and not one of the patients that I pushed to have thrombolytics ever got it because nobody believed this.
No.
It's funny,
This is what I wanted to disagree with before. It absolutely is not because they don't believe it. They might say that to you, especially you in particular, but that's, in my mind, clearly not why they're not giving this intervention. The reason they're not doing it is because they don't want the risk of giving a systemic thrombolytic. And if they could get away with not doing it, I
think this is I love arguing with you, but I think the classic problem with arguing with you is that you live in an American bubble. I don't think
it's not an American bubble. I know where I live. I live in America. That's what I'm practicing based on. I'd go even further.
Nobody gives a shit about risk.
My bubble, not even in America. It's my bubble. That's
in my conversations.
My
ICU docs, there's no. If they think it's the right thing, they think it's the right thing. Nobody's worried about the risk of giving.
I talked to plenty of Canadian.
Thing,
that you lost it. They might not be talking to you the way they talk to me, but your Canadian ICU brethren absolutely do not want to give thrombolytics, and I don't blame them. At the time where your only choice was half dose or full dose, I wouldn't want to give thrombolytics. It was a shit show to give thrombolytics at that rate. It's always rolling the dice, especially in the older patients. So no, they might tell you it's not evidence-based, but what they're really saying is, I don't want to take responsibility for causing an intracranial hemorrhage in this patient.
But let's take it. So you've tried to come at it from one aspect. So let me try to take it from a completely different perspective. I think we can both agree by 14 days, patients in both the groups in these trials, or whatever, it was 7 and then 30 and then 90 or whatever, have identical clinical outcomes.
Absolutely. If you can make it that long, you're fine.
So if you have two groups of patients that at the end of the day have identical clinical outcomes, and in one group, 100% of them, even though risk of thrombolysis is very low, yet get thrombolysis, and the other group, 10% do, which group would you rather be in? Like, the outcomes, we agree, are identical down the line. I would always rather be in the group that instead of giving 100% of every therapy we do, like people can be boogeyman about thrombolysis, but it doesn't matter what the therapy is. This reminds me a lot of chest tubes. And actually, it's a really good analogy because in a very sick patient, trauma patient, unstable, a chest tube is you just go in and do it. Give me a spontaneous pneumothorax though, and people argue about this all the time because, I can put in 100% chest tubes up front to avoid the 10% of patients who actually need it. It's insane. High P though, those are the numbers. They have identified a group of patients where the clinical outcomes are going to be identical no matter what we do. But if we use the wait and see approach, and this may just be my bias, I always think wait and see is better. I got a Jerry Hoffman in the back of my head at all times. The wait and see approach here resulted in a 90% decrease in invasive therapy or therapy with harms with identical clinical outcomes. That is a win.
You can't say that because you're ignoring the rescue therapies. And
that is the rescue therapies. It's a 90% because 10% in the intervention group, 100% of people got therapies. In the other group, 90%. About half of that was the exact same.
Okay, so if I understand, if I restate what you're saying, in the group that was selected not to need rescue therapy in the anticoagulation group alone, they did just as well as the patients who got the intervention.
No, in the overall group did exactly.
No, I understand that, but that's not where your argument stems from because the 10% got rescue therapies, so they no longer are applicable as a comparison.
No, it is applicable because this is like the people who argue that I got to give prophylactic antibiotics for a dog bite. You're arguing I got to give 100 patients antibiotics to prevent 5 people from needing the antibiotics in 5 days. If the outcomes are identical,
you're saying just waiting and giving the patients when their news score bumped was just as good as giving it up
What you should do is what we would always do. Don't give it, this trial proves, do not give it to everybody up front. Wait and see.
Now, I want to restate Justin's point here because it's such a good one. And he Took me a while to really get what he was saying with this point, and then I want to make sure you get it right away because it's really crucial. His contention is that if you believe the patients who meet the entry criteria for this study are the ones you should empirically give intervention to, then simply waiting for their criteria for rescue therapy, which is hitting this news score greater than 9, a early warning score, would save 90% of the patients in intervention without any increase in negative sequelae. And he's absolutely right. That point is well taken and true. So then the question becomes, are these the criteria that we should be using to actually decide these patients clearly need an intervention? And so obviously by this study, they shouldn't be. So what actually got patients in? So patients had a RV to LV ratio greater than or equal to 1. And Josh and I have already spoken about the fact that 1 is probably not the number, that is too low a bar as a cutoff. They have to have elevated biomarkers like troponin. That one's pretty good. And then they have the clinical cutoffs. And that was you needed 2 or more of heart rate greater than 100. So just the barest definition of tachycardia. Systolic blood pressure less than 110, which, that one's kind of loose in my mind. If it was a systolic less than 90, that would have been better. And that would have, along with the heart rate, given us a shock index greater than 1. 110 might be a little bit too soft. And then this one, and this is the one that I look askance at, a respiratory rate greater than 20 or pulse ox less than 90 on room air. And the pulse ox less than 90 on room air is okay. My cutoff in the EMCrit risk stratification is a pulse ox less than 90 on 6 liters nasal cannula, which means you're eliminating all of the sources of hypoxemia except for shunt. I think that's a fairly legitimate cutoff. Room air pulse ox less than 90? Yeah, it means something. I'm not sure if that's sick enough. And respiratory rate greater than 20, that's kind of a joke, right? Respiratory rate greater than 30 is the number I've heard bandied around for. Oh, that doesn't look so good on that patient, but greater than 20? That's just regular pulmonary embolism will usually have a respiratory rate greater than 20. So I think he's right, is what it comes down to. I think that this, because they needed the numbers, is a group of patients that aren't that sick and therefore don't need an intervention, while the previous trials that had much higher sequelae rates had a much stricter entrance criteria, much sicker patients. All right, let's get back in.
Now, what I would love you and Josh to talk about is, and the hard part here to me, and I don't want to shoot myself in the foot, but I love to have a good honest conversation, is generalizability. I don't know anything about these trials, but I can imagine the research center has 24/7 ICU coverage, which most places don't have. I can imagine somebody's doing a repeat echo in the middle of the night. I can imagine the decision to escalate to rescue therapy is way better here than in any community hospital. So that's the biggest argument against me, is that in the average setting, the ability to recognize a deteriorating patient and the ability to get them to rescue therapy is going to be worse in this trial.
Yeah, that's absolutely a great point, and a point I would make. And I think we're going to discuss that in just a little bit. Let's really, as the last question, put your feet to the fire. So you have a pulmonary embolism, and I hope it never actually happens. And it's hemodynamically significant, but you're not hypotensive. But you're at the high risk end of that D category, and you're in your hospital, and they offer you, hey, we could give you 16 milligrams of systemic thrombolytics over 6 hours, or we could watch and wait and see if there's any decompensation. Which would you choose at this current juncture?
Yeah, like good evidence-based medicine, it depends on which hospital in which setting I am.
I don't know which hospitals you're at. Choose whichever you like.
But like even in the exact same hospital, and this is the problem, it comes down to exactly what you're saying. So if I'm in my hospital functioning at its best, where the hemodynamic consequences are enough where I'm being put in the ICU where they're monitoring me, I want the wait and see approach.
Okay.
Last time, when I worked 2 days ago, there were 55 patients waiting for their internal medicine consult. It was like more than 24 hours until you were going to be seen by anybody. In that case, just get me started on thrombolysis, because I know that I'm in the back fucking corner somewhere. So I do think there is judgment. That's why I think the conversation, if you're having it with Josh, I love the generalizability, like how it changes between gold standard, I'm in an ICU being monitored with an echo every 4 hours, versus versus what you do in the community. And I actually think it's the exact opposite of what most people think. People think you should be more aggressive in the big centers, but I actually think a lot of the time it's the exact opposite. You got to be more aggressive in the communities because you don't have those kind of resources. I think that's true in a lot of situations, and it gets underlooked. You have the opportunity. You're with your patient nonstop. You can wait and see. That's not true in little town nowhere, and that's not just a PE thing. I think that's a bigger point in resuscitation.
Yeah, I'll put one last little wrinkle to what you just said because I agree with every word of it. Even if you're in a big place and they're not in the midst of the Hawthorne effect of a trial like this, if I decide to thrombolyze them early with low-dose systemic thrombolysis, they're going to get their intervention. While if they go to the ICU, they might be at the beginning of hemodynamic decompensation. And for that same bias of the lack of desire to intervene, it might be quite a bit before they actually will pull the trigger in places that don't have PERT teams. And you've correctly identified the downside of PERT teams, which is they're probably overly aggressive at intervention. But the downside of not having PERT teams is I think there's an under-aggressiveness for intervention.
I think without the Hawthorne effect, though, both groups can be effective. 'Cause I didn't see in this trial, like how often did they, like if you're doing thrombolysis over the course of 9 hours or whatever, you should turn it off as the patient gets better. I don't know how often they stopped or what the average dose was here.
But the average dose was 16.9 of the 18 for the two catheters.
Okay, so they did pretty much the full dose, which is fine.
And my guess is they weren't stopping it early. Like it was probably like the line broke down and stopped infusing because at that dose, you might as well just finish it.
But that would be my deal. Like if I worked in the ICU, if I did what you did, I would. But before this, I probably would have been at the bedside pushing 5, come back in an hour and seeing, pushing 5. Like that's would have been my mindset on how to do this. And I think that also falls apart in a trial because what's going to happen is you're going to get the full whatever dose people decide. It's going to be 25. You're going to get the full dose, especially if you go back to the IV. Whereas I love these. Like the only benefit of the catheter is people have been using really low doses, and I think it's perfectly fine for the IV. But people are going to cross contaminate that. And again, you're giving the exactly right messages on like 99% of everything I hear you say about PE. I 100% agree with you. It's just on which population you jump straight into this and which you don't. Yep. And it's hard. And it's such a small percentage of PE that it's like we've already spent 40 minutes talking about something that's like
it's a good conversation though.
It's interesting. It's really good, but it's a sliver, right? Yeah.
Yep. But I think it has broader application to a lot of the questions we are exposed to in resuscitation because it's the same thing. We're talking about very small groups of very rare patients, and you have to decide definitive things to do at that individual patient's bedside based on evidence that isn't fantastic. So. All right, man. This is fantastic.
Dude, it was a pleasure to see you, yeah.
As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our Getting Out on Time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.